You'll know when you have a wild woman. She'll practice her craft without boundaries. She is truly autonomous. Her loyalty is only to the family she serves, a midwife who will not allow herself to be held back by a system she didn't create.
This podcast is for the birth keepers who want to grow and change. We are open to learning through self-reflection and supportive community. We are creating this space to explore without judgment. We are remembering we were
Born wild. Hello, everyone. Welcome back to the Born Wild podcast. We're your hosts, Sophia
and Lea.
And Nina should be joining soon. Clover, Chelsea, and Emma couldn't make it today. We wanted to reintroduce everyone to our guest today, Jen Santos. She has already been recorded on an episode with us, which I will link in the show notes. She's a chiropractor, and today we're going to talk about tongue ties and lip ties. We recently did a training with Jen, and we were like, oh my gosh, we need to get this information out to other birth workers. And it was so visual. We're like, is that even possible on a podcast? And she has a great story, actually, she can share, but she's like, I'm up to the challenge. I think I can do it. So I'll just let you, Jen, introduce yourself again, or for the first time for people who didn't hear the last episode. And we'll dive into it.
Awesome. Hello. Thank you for having me. I am Dr. Jen Santos. I am a chiropractor in Sonoma and Napa counties. I primarily focus on perinatal and pediatric care, and I teach at the Chiropractic College down in Hayward, Life Chiropractic College West, where I teach obstetrics, gynecology, pediatric pathology, prenatal and pediatric adjusting. And then I also am the overseer of prenatal and pediatric cases that come in through their outpatient clinic. So our big focus is on babies and mamas and pregnant people in general. And I also am the West Coast instructor for dynamic body balancing, which was invented by Dr. Carol Phillips, who really is where a lot of the spinning babies stuff came from. So most people don't necessarily know Dr. Carol Phillips, but they know spinning babies. So side lie and release, forward leaning inversion, those are Carol's. So yeah, super, super exciting.
Sweet. Okay. So I'm curious about how you first...
Oh, my dog.
It's okay.
Sorry.
Totally casual. How did you, is tongue ties, because that's our focus today, tongue ties, lip ties, how did you, is that part of chiropractic school? Where, or did you have to do additional training to learn about that? Because it's kind of like a quote unquote newer thing, and people are questioning, has this always been around and we're just now diagnosing it better? Or is this a thing that's been caused by the environment or supplements? There's lots of kind of rumors floating around, but how did you get introduced to it?
Yeah. So I think, no, we don't learn. Well, I did not learn about it in chiropractic school. One of the biggest things that I feel like most people don't know about chiropractic is chiropractors in the state of California are primary care physicians. So our entire schooling, we go through about 8 years of school. So we have undergrad and then our doctorate program. And during that school, we do blood work. Some schools do blood draws. We have to do 10 gynecological exams, 10, what are they called for guys? I always, proctological exams. I'm always like, what is that?
Exams.
We do classes, we do an ENT class, we do dermatology classes. So because we're trying to, because we are primary care, so it includes all of that stuff. And I feel like not a lot of people realize that is with chiropractors, that it's more than just adjustments or fixing back pain. So I first got introduced to tongue ties really in clinical practice. I just started seeing, what is this, why is this extra tissue here? What is, and I think I remember Googling like, extra like frenulum tissue or something like that. And it popped up as lip ties, tongue ties, ankylosing. And I was like, oh, wow. Like, okay. And then I went to a seminar out of Australia, where there were a lot of Australian chiropractors and New Zealand chiropractors, and they were talking about lip ties and tongue ties and the effects, the neurological implications of them, and how it affects the person that has them. And so kind of saw that in clinical practice, and so started kind of like diving down that rabbit hole. Now I teach about ties in the school. So one of the cool things about being an instructor or professor at the chiropractic college is I'm able to incorporate stuff that I see in clinical practice repeatedly, because we're primarily pediatric prenatal practice, that I'm able to see that and then start really diving down the academic rabbit hole of looking at stuff. And I'm also able to, because I'm at the school, able to pull research that would cost me a lot of money that I don't have to pay for because the school can get different studies and stuff. So I think that's kind of how I was first exposed to it. And as far as, my opinion on it, I have many different opinions as to like why we're seeing an increased rate. I don't believe that. I've been in practice 8.5 years, and prior to that, I was in clinic in school for 1.5 years. So let's just say 10 years of looking at babies and different things. And I can definitely say, although like I'm for sure seeing a lot more babies now than I was, 8 years ago, I do think that there is an increase, and there's a lot of theories as to why that is. You kind of hit the nail on the head with that. I think some of the theories that make the most sense to me, the first one would be the increase in using folic acid instead of using folate, which is B9. A lot of people are taught that B9 is B9 is B9 is B9. And in school, we're taught that folic acid and folate are interchangeable terms. And when you go down the rabbit hole of, what is it? Chemistry, biochemistry, it's really not the same. B9 and B9 folate and B9 folic acid are two different things. And folic acid has to be methylized through the liver. And so if you have somebody with like the MTHFR gene mutation or inability to methylize different material, vitamins, I think we're going to see an increase of that. And we are seeing an increase in those genetic mutations. And so I do think we are seeing an increase in that. And that is one of the ones that makes sense to me. Unfortunately, in clinical practice, a lot of the people, I think most people that I see that are pregnant are taking folic acid as opposed to folate. And people go, well, I can't remember which one. And I'm like, well, remember, acid is bad for you. Right? Like acid is bad. So if you can just remember that.
Could you explain for people who don't know, like how that could even come across as a tie? Like, what is it doing in the body?
Yeah. So best way to describe it without going into like 4-hour-long conversation of biochemistry is basically the reason that people take B9 in pregnancy is because we want to avoid neural tube defects. And what that means is midline central nervous system defects. So things like spina bifida, cleft palates, that kind of stuff. So the way that I describe this, and if you are a biochem person, you can come at me privately, because I'm going to describe it as though, for a very simple,
talk to the lay person.
Yes, exactly. But basically when you take folic acid, your body has receptor sites that it joins to and binds to. And so if they're collecting the folic acid, but then unable to go through the process to break it down and methylize it and become folate, then basically what's going to happen is any food that you eat, your body's going to be like, I don't need any of that folate, because that's what's found in nature. So in like green leafy vegetables, that kind of stuff, your body's going to say, I don't really need that. And so you're going to get rid of that, but then still have the receptor sites gunked up from your folic acid. So basically what I call this is some sort of like, it's a pseudo deficiency. So instead of having a deficiency where spina bifida is where like the bones don't come together properly, or in the like a cleft palate where the bones don't come together properly, like in the mouth, it kind of is like a pseudo deficiency where we get extra tissue in the midline. And I surmise that this is what we see with like tethered cords. So down in the sacrum area, you can get like the spinal cord can be like extra tethered. And then in the mouth.
Oh, I know.
Yeah. Yep. And then in the mouth, we see extra tissue as far as tongues, tongue ties, lip ties, that kind of stuff. So I think we are seeing more of them, but it's sort of, I think part of it is also like, you go on to a mom's group and now everything is responsible for a tongue tie. Oh, your baby doesn't sleep through the night. It's a tongue tie. Oh, your baby has gas. It's a tongue tie. And so it kind of reminds me of like when you buy a new car and you're like, oh, I haven't really seen that car on the road. And then you buy a new car and you see it freaking everywhere, right? Like it's a little bit like that. So I'm not a big fan of just diagnosing ties left and right and for everybody. And there's a lot of stuff that I think can be done prior to having a revision that should be done prior to revision. Because if it could save from a surgical procedure, I think that would be really good. The other one that I think, and I mean, this could also be a whole topic, and I don't want to step on toes or make anybody feel bad or wronged. But the other one is prenatal ultrasounds. I'm sorry.
I said wrong podcast.
Oh, the other one is prenatal ultrasounds. I think that when you look at the research with prenatal ultrasounds, we have never really been able to do a study looking at people who have been ultrasound versus people who have not been ultrasounded. And, some people can say, oh, well, I didn't have an ultrasound. And at this point, most people, I'm going to say that we're all the same age. Most people our age, whether or not they choose to have an ultrasound with their pregnancy, if their mother had an ultrasound with you while you were in utero, your eggs were ultrasounded. So the research shows in mice that effects on tissue all the way at a genetic level are affected for 10 generations of the mice. So we don't know what that means for adults or for humans. But
it's my mom right now asking if she had an ultrasound. Because I know they kept our sex a surprise. So
yeah,
sure.
Yeah. But it's one of those things. There's a really cool CNN and in the early and mid 80s had run a expose or little like news clip about warning people of the possible dangers of prenatal ultrasound. And one of the Dr. Tom's has a quote that says like prenatal ultrasounds have always run with the Titanic mentality, safety is ensured, so precautions are unnecessary. And I feel like that's really how ultrasound is kind of viewed up until, for 50 years, we did x-rays on pregnant women and then finally decided we shouldn't do that because it was causing leukemia in all the little kids. I could do an entire podcast just on prenatal ultrasounds because there's a lot of information there.
Okay, we're bringing her back, Chris.
And you're going to be our number one contributor.
There we go. But with all of this, there are clearly reasons for prenatal ultrasound. So it's not just to make everybody feel bad and wrong about if you've had an ultrasound, you're doomed. That's really not the point. It's just, it is a medical procedure that really should be done intelligently to look for pathology when pathology is suspected. And that's kind of my opinion on it. Yeah. But tongue ties, but I think, if you go on, you can actually Google it. If you just Google Carol Phillips prenatal ultrasound YouTube, it will show that CNN thing. Now it is from the mid 80s. So it's pretty, funny looking, but when you consider that this was a question that was raised in the 80s and it has not really been answered. And there's a ton of research. Unfortunately, most of it is outside of the United States, but there's a ton of research to suggest that it is not a passive modality.
And just to clarify with everyone listening, Doppler and electronic fetal monitoring is ultrasound technology. And actually, I was surprised to learn more powerful than ultrasound. I assumed with getting a picture that it would be more powerful. But my understanding is 5 minutes of Doppler use is equivalent to a half hour of ultrasound. Yeah. So we always try to educate our clients on that because it's not about swaying you away from it. It's just making sure you have all the information so that you can decide what you want to do for your baby versus later finding out and being like, "Ooh, I might have made a different choice."
Right. Exactly. Yeah. And so, yeah, that's again, in my office, I don't. Oh, now your dog's going
wild. That's the title of this podcast.
Right, exactly.
And Dogs Gone Wild.
Yeah, in my practice, I would say most everybody gets prenatal ultrasounds. My job is not to scare people away from making decisions. And it is kind of a bummer because although I have primary care, I'm not allowed to, how do I say, I'm also not allowed to practice obstetrics or interpret even, I'm not allowed to do prenatal ultrasounds with my license. And so it's one of those things where I really feel very strongly not to freak people out or whatever, but it's also something where I feel like people are just plain being lied to and not educated on the possibility that at least there's question as to whether or not the safety is there. And they're just, oh, it's just sound waves. I love that comment. But anyways, we could do a whole podcast on that.
So there's going to be probably 2 different types of people listening to this. One are going to be birth keepers, whether that's midwives, student midwives, doulas, and the other.
Yeah, I'm going to interrupt you for a second because Nina's here.
Hi.
Hi. Sorry to interrupt.
Welcome back from Cuba.
Thank you. I'll tell you all about it when we're not on the podcast. We didn't even really do a check-in, so we'll do a check-in next time.
Sounds good.
So much has happened for everybody.
Yeah.
Anyway, go on. Sorry. I just wanted
Great. So I was saying so there's birth keepers that are listening, and then there's also parents, and so I guess the question would be as a parent or as a midwife, how are we diagnosing these? When is revision needed? When is chiropractic care needed? Can you help people figure out how to go about diagnosing, because you were saying like you don't want to like overdiagnose it, make it be a bigger issue than it needs to be. So like where is the boundary there?
Yeah, so I these ties are fascial in nature, so they're extra tissue, either at the roof, like where the top gum of the mouth meets the inside of the lip. So when you flip your lip up, your top lip up towards your nose, you'll see that frenulum. Now, everybody is supposed to have a frenulum. So I feel like I was saying with the cars, once you get a new car, you see that everybody has this car. Well, yeah, sure, but everybody has a frenulum. That's kind of normal anatomy.
You know, everyone listening just stuck their tongue up there.
I know, right? They're like,
oh my God, I'm tied. I felt
something. So everybody has a frenulum. That's where the tissue meets the upper lip tissue meets the gum line. That's supposed to be there. That is normal anatomy. Now, the issue is when that tie is, or that frenulum is more broad than it should be, it's thicker than it should be, or it's shorter than it should be. And so it restricts flanging of that upper lip. So the upper lip can't like flip up and touch like the nose, for example. So the way that you would do this, to look at it, I classify it in kind of first class, second class, third class, and fourth class. So there are 4 classes, one being kind of like, that's normal. Everybody that has normal anatomy with that, it should be like a class 1. That's like the least intrusive. And then it goes from 1 all the way to 4. That's my preferred method, because then it also doesn't have confusion with tears, like perineal lacerations. And that's the same way that they class those. So that's obviously, those are 2 different things, but I think it's easier, especially for birth workers, to know that that's sort of like how they're classed. If you see things like baby is having a difficult time latching, that lip can't flange up to go onto the breast, that's all signs that they should be evaluated by a pediatric chiropractor or craniosacral specialist, to kind of figure out what's going on there.
And just to clarify, because you are a cranial sacral specialist, but not all chiropractors are.
Correct. So I am a pediatric chiropractor. So what that means is I've gone through regular chiropractic college. And so I've done chiropractic college, and then I went through a 3-year program after chiropractic college, specifically focused on the prenatal, perinatal care and pediatric care. And as of right now, like we're in the North Bay in California. So there are 4 perinatal pediatric certified chiropractors in the North Bay. All of us are at Acorn Chiropractic Club. So then I, what about that also? And then I took dynamic body balancing. So I'm also a facilitator for dynamic body balancing, which is a variant of craniosacral therapy that uses more movement. So things like craniosacral therapy in the upledger world, it's a lot of like sitting still and just like holding points. Whereas the theory behind dynamic body balancing is that things happen, traumas, injuries, things like that happen in a torsional component. So a rotational injury, so that what we want to do is use motion or movement from the body to kind of unwind any torsion that has occurred within the body. So it is, so as far as specifically chiropractors that are looking at this, you wouldn't just go to a general chiropractor and say, hey, is this something in your wheelhouse? You want to have somebody who, this is what they do. It doesn't necessarily need to be a CACCP chiropractor that's done all of this, but it would be somebody who has done extensive pediatric training. Yeah. So yes, I am craniosacral certified in a variant of dynamic body balancing. Yeah. So where were we? So that would be class 1 would be kind of like normal tie with free range motion of that lip. The second one would be that the tissue is a little bit thicker, and it comes down to like more of like the midline when the lip, or to the gum line when the lip is flipped up. What we'll also see is when you flip the lip up, that tissue right there blanches, so it turns white. And that's an indication that there is a tethered oral tie there. So there's not that restriction is more restricted than it should be. So typically with a class 2, 3, or 4, we're going to see that whitening of that tissue when you flip the lip up. The third one would be the tissue inserts at the gum line. So at the gum line, you'll see that tissue, that frenulum kind of attach all the way down to the gum line. That is typically going to be more broad than the other two. Not always though. The other thing that happens is if you flip the lip on the inside of the lip, you'll see like a fanning. So it'll be wide and then it'll kind of like cone down to that tie right at the gum line. And so you'll see this kind of wider base at the top and then kind of fanning down. And that'll be kind of like at the gum line. The grade 4 is where the tissue is tucked under the front of the hard palate. So the hard palate should kind of feel like a rainbow side to side and then also front to back. And we do a lot of like palate work with babies as well. And so if you see a grade 4, that's where like the tissue goes all the way back underneath, tucked under the hard palate, and you'll see like a ridge. Typically with a grade 3 or 4 or a class 3 or 4, you'll see once the teeth start coming in, they're gapped, and that gap will remain there because that tissue is in the way. So it'll keep it out. Again, a grade 4 with a lip is the most severe, and that is most likely going to prevent baby from being able to flange and get onto the breast, which will decrease the success of breastfeeding. The other thing that I see sometimes is they'll say like, oh, well, baby can latch on, but I'm not making enough milk. Well, there's a lot of hormones that go into breastfeeding, but one of the things with that is the way breast milk works theoretically is through basic supply and demand. So if the baby is getting a good latch and nursing, theoretically the body will make enough milk for baby. So if mom is not making enough milk, I typically am going to look for ties or any biomechanical dysfunction within the latch to see if there's something going on that doesn't allow for a good withdrawal of milk, which would then decrease mom's milk supply because it's not working in that supply and demand. Any questions about lips so far? Does that all make sense?
I guess if there's issues with breastfeeding, refer to somebody who can support them with that. Would you ever have those ties and there not be an issue with breastfeeding, or is it like?
Yeah, so it is possible. I hate this terminology, but this is like, so forgive me with this, but typically people who have breastfed before, I find I don't like it. I don't like this wording, but their breasts are like broken in, or their nipples are broken in. And so a lot of times, and if you have, 2, 3 other kids to worry about, you're not necessarily taking the time to sit there and like contemplate cracked nipples. You gotta go. So sometimes I'll see ties and I'll be like, are your nipples okay? And mom will be like, yeah, they're fine. I'm like, there's no way they're fine. Let me see. And then and I'm like, let me see, like, is it okay if I look? And like, they have like cracking, or they, you know, and I'm like, this isn't, or like, I'll want to see right after the baby gets off the breast and it's like that lipstick shape, or, you know, and I'm like, you just don't have enough time to sit. I feel like first moms typically like sit and nurse their babies and look down, and they're, you know, and then by the time they get 2, 3, 4, they're like, I don't have time for that. Like, I'm just on the go.
I think some people just chalk it up to like, it's just not comfortable to breastfeed, you know,
Yes.
and I just think that's their normal.
Yes. Yeah. And that's the thing is like, I also think the language is weird when people say like breastfeeding should be pleasurable. It's not. I think that terminology is so weird because I think that's confused with like sexual pleasure, and that's not really what's happening. It shouldn't be painful though. And if breastfeeding is painful, there's some sort of dysfunction occurring. And most likely it's the baby, not mama. The other thing that happens is the elasticity of the breast tissue, after they've breastfed once, twice, 3 times is more elastic, if you will. And that's sort of part of that, like breaking in the breasts, if you will. And again, I don't like that term, but it's the best we have for now. So I think that's also something else, is that the tissue is easier to feed off of, because typically there's more pliability in that tissue once they've breastfed before. So they might not even notice, and then I'll see it and I'm like, okay, what do we do here?
And I assume the same applies for tongue ties, that
yes,
some people can just like get through, but
yeah.
okay. What are the categories there?
So categories for tongue ties, again, I go through and do 1 through 4, 1 being sort of like the 1 being like the with a tongue tie, we're going to see that's going to give you like the classic heart-shaped tongue. So that's going to be an anterior, so it's going to have tissue, okay, sorry, let me back up. The tissue, I'm like, so with the tongue tie is going to be under the tongue. So it's sublingual is what they call it. It's under the tongue. And if you lift up your tongue in the mirror and you look, you'll see that you have a frenulum there. Again, everybody has a frenulum. That's how the tongue attaches to the base of the mouth. So you want to have a tongue tie, otherwise your tongue would hang out of your mouth like a dog. So it tethers to there, but you want it about in the middle, about the middle of the floor of your mouth. So you'll see it kind of there. Class 1 tongue tie is going to be where the very front of the tongue is tethered to the bottom of the mouth. So we call this an anterior tongue tie. Or this is often said like the apex of the tongue, the very, very tip is tethered to the bottom. This is the easiest tongue tie to diagnose. And there's no ambiguity here typically. I have had people say that they went to a doctor and they say, oh, it's totally fine. And I'm like, no, the kid can't, the baby can't put their tongue past their gum line because it's so tethered, or they can't lift their tongue up. That's an issue.
Is that where you get the heart shape, Jen?
Yes, that's where you get the heart shape. So the heart shape, or sometimes people call it like a snake tongue, where it kind of looks bifurcated, or like 2 little tips as opposed to 1 nice round tip. So if a baby is crying and they have that little heart shape, that indent, that's typically going to be an indication that there's a tie there. A class 2 is going to be considered also an anterior tie. This is where it inserts the posterior tip of the tongue. The heart shape is not necessarily evident, but it can be the tie can clearly be seen. So it's more anterior than like in the middle of the base or the floor of the mouth. A class 3 is considered a posterior tongue tie, and 4 is considered a posterior tongue tie. So a class 3 is going to be thinner than a 4, but it's going to be, you'll feel it when you go back to the base of the tongue underneath where the floor of the mouth and the tongue meet at the back. You can run your finger over it, and often you'll feel like this little speed bump running front and back. So you'll feel this little speed bump. It should kind of, if you take your finger and run it behind the gum line. Now, typically this is going to be an infant's, but you're bigger than an infant. If you take your finger and run it back behind your gum line, you should just feel a nice tissue there that doesn't have like a little speed bump. If you feel that speed bump kind of at the base, you'll often perhaps direct you into a tie situation. A 4 is where you might not even see the membrane, or the tie, but you'll feel when you stick your hand in there. So the other thing that kind of gets me is, unless it's an anterior tongue tie, a posterior tongue tie has to be palpated. You can't just look and see it. Whereas an anterior tongue tie, that's going to give you that heart shape. It's going to look like a little string that's holding the tip of the tongue down. The baby's not going to be able to put their tongue up to the roof of their mouth. And that's going to not be good. So a posterior tongue tie, you can't send a picture to Kaiser or a midwife and be like, hey, does this look tied? Because you can't tell. It's not, you have to palpate it. You have to go in there and feel it. The other thing that I want to see is, I'll stick my finger into the roof or into the mouth, and I want to see that they're able to push my tongue, or not my tongue, that would be weird, push my finger. I want to see that they can push my finger up to the roof of their mouth, and I want to see their tongue creating that wave that we like to see with breastfeeding. And if they're not able to do that, that's another indication that some sort of dysfunction is happening. It could be a tie. And so we'll talk about that as well. A class 4 is the most commonly missed type. It's a posterior tongue tie again. And this is where a lot of the discussion comes in, because you can't necessarily see it. And so it's sort of one of those things, well, if you can't see it, maybe it's not there. And sometimes it's very easily palpable. You can palpate it and feel it, and there's dysfunction in the tongue occurring. So again, but the class 1 and class 2 are the easiest to see and make sure that those are so easy to see.
And then the order of the classification, is it from like least in quotes severe to most severe, or is it more like harder to diagnose? Like, so, or is one worse than the other?
Yeah. So I think for the purposes of this, with the tongue, it goes the other way. So typically this is like easiest to diagnose is going to be a class 1 there. I mean, most anybody can see, yeah, that's an issue. All the way down would be a 4, which is the most commonly missed, but it's also the hardest to diagnose. It's also the least severe. So this is the opposite with those, and I'm not really sure why they do that, but that's what it is.
Mm-hmm. Yeah.
Yeah.
Okay. Yeah, I'm like flashing back to some sort of story I heard about how midwives back in the day would always keep like the pinky nail really sharp to like cut ties or something. I don't know if that's actually true.
Well, I go back and forth on that story. I've heard that quite a few times, and I'm like,
maybe it was just for me every time.
No, like, I don't know if that's just that to me is like, oh dear God, I don't want a midwife near my baby. Right. And like, I feel like that might be like part of the persecution that you guys have had to deal with and the crazy stuff that people say about midwives.
Fingernails.
Exactly. Yeah. I'm like, cause I don't know that that's like, one, would that necessarily be sanitary? You know, like, I don't know.
No, it's not clear now.
I don't know. But I have seen like a grade 1. It was the weirdest one that I had ever seen, where it was a very small tie from the very tip of the tongue all the way down, but there was a hole between the, like in the middle. So it was tied in the back where it should be, like everybody. And then the very, very front had this weird little string that was just, and I was like, man, I didn't, but I was like, I just really want to take scissors and just like clip it. And in that case, I was like, maybe if there was something sharp enough that a midwife had, they could just, but so, you know, but it was a very obvious tongue tie, and that baby could not raise their tongue above their gum line. And so that one was incredibly obvious.
I have 3 questions, and I know I'm like paying attention to the time that we have you. So maybe I'll just throw them all out there and then you can see what makes sense.
You'll have to remind me.
I want to know if tongue and lip tie is only a breastfeeding issue or if there's complications outside of breastfeeding. I wanted to know, I'm trying to think, maybe there's only 2 questions. I wanted to know, how do families and midwives find you, in air quotes, like people who aren't near here, like if they're wanting to send families to somebody like you, like how do they find those resources? That's reminding me of my other question. Oh gosh, and now I just forgot it again. But maybe start with those and I'll write it down if I remember it.
Okay, so the first one I'm going to answer out of order. Your second one that I'm going to answer is the how do they find help? I can speak for the chiropractic profession. If you want to find a pediatric chiropractor, the best website to go to is icpa4kids.com or .org. There is a section where it says find a chiropractor. You can put in your zip code and it'll find you the nearest chiropractor. Theoretically, you would want to find a CACCP or a DACCP. That means that they're certified through the Academy of Council of Pediatric or Family Practices, or that they have their diplomate. So either one of those would be good.
So however, I'm remembering you said that not everybody knows this like tongue tie stuff through chiropractic.
Yeah.
So even if they don't have the ability to like diagnose, they could still support a baby who has it.
Yes.
Okay.
And so here's the other thing with this. This will kind of answer your question, so I'll go there. But so they could go onto that website. The other thing is to call. If you find a pediatric chiropractor on that, call and say, do you have experience with tongue ties or lip ties? They're sort of this weird one, they should absolutely be willing to answer you about that. In our profession, the ICPA is an organization, the International Chiropractic Pediatric Association is one that I teach for, but we're in the process of adding a tongue tie class, lip tie, tongue tie class to that certification program as well. So pretty soon we're going to have more chiropractors competent in this issue as well. So that's one. The other one, it's not just a breastfeeding issue. There are a lot of things to consider with this. The first one is just because baby breastfeeds fine, or perceived fine. There are a lot of issues with this. One of the things is when babies breastfeed, if they are on, let's say, the left breast and they're being cradled like in a traditional breastfeeding cradle position, let's say, the right side of their face is against the breast. And what that is doing is with their sucking, they are getting left cortical input to their brain. What they're also doing typically is using their hand So they would, in that position, if they're on the left breast, their right side of their face is against the breast. They're looking at mom kind of up and to the left, and then they're using their left hand to kind of like move their hand and play with mom. We're stimulating that side of the brain. Then we flip to the other side, and baby is breastfeeding on that side and looking up and to the right, getting stimulation on their face, which is stimulating the left side or the right side of their brain. So what that's going to do is help develop their corpus callosum, which is the thing that makes the left side of the brain and the right side of the brain communicate with each other. So that's really imperative for neurological development. So it's a lot about neurological development. The other thing that happens is the hard palate in the roof of the mouth. If the tongue is able to go up all the way, when the nipple is in the mouth, they're using that to push it against the roof of their mouth, the hard palate. What sits on top of the hard palate is the sphenoid, which is this big, beautiful butterfly bone, and it has 16 other bones that attach to it. So it's kind of like the keystone to all other cranial bones. So in that sits the sella turcica, which is where the pituitary gland sits. Pituitary gland is responsible for all kinds of hormones that, and one of them is going to be like the sleep hormones that babies need. So when baby is nursing, you got a couple different bones that are going up and down and pulsating, which is stimulating that gland to produce more. And so it's also very hormonal. It's neurological, but also very hormonal to make sure that the babies are getting the proper hormones as well. So a lot of times,
like the whole milk drunk.
Yes, exactly.
It's not really the milk.
Well, it's a full belly, but yeah, I mean, it's a big barrage of those hormones, and they're pumping those and being able to get those out to their system. And that's through, and the other thing with that is that's through the craniosacral rhythm. So there's clear fluid in your spinal cord that goes from your bottom up to your head, washes your brain out, takes it back down. So that's the cerebral spinal fluid. And what we want to see is that that is moving throughout the system properly. And so that's going to help with that. So those tend to be babies who also, if there's a problem moving that cerebral spinal fluid, those are going to be babies that cry a lot. They're not doing it simply to drive you crazy. What they're doing is they're trying to increase the amplitude at which that cerebral spinal fluid flows.
They're problem solvers.
Yes, exactly. So to me, I don't look at babies as like good or bad. All babies are trying to do what they need to do to survive. That's their job, is to grow and survive. And so when we see babies that are constantly crying, then we get, oh, it's a colicky baby, or, oh, it's a high needs baby. A lot of times what we need to do is balance that flow of cerebral spinal fluid, balance their system, and then they're able to like chill the fuck out and not cry to help move that fluid. So it's really their way of communicating. They can't articulate, hey, I need this, but they're just going to cry, which is going to increase that amplitude.
Mm-hmm.
So
I have a question. Is there a relationship between tongue ties and like the formation of the palate in terms of breathing through mouth versus nose, and then further palate development like later in childhood?
Yeah. So typically what's going to happen is there's a osteological process in bone development called Wolff's Law. And basically that means the bones are going to grow in the shape that there's more stress put in the area. So when the baby is able to push their tongue up, that's going to help create that arch in the palate. And sometimes we'll see babies with like a tented palate or like a high palate. Those babies also are going to have problems breastfeeding, and that's typically like a cranial issue that needs to be worked out. So yeah, over time, we want to see them being able to breastfeed properly so that they're cranium is being molded the best way possible. Yeah.
Yeah, I have 2 cranial sacral stories real quick. One was when I was a doula, one of my first clients and her baby just screamed nonstop for 2 days, like until she would fall asleep, pass out, and then wake up, like not crying. She was like screaming.
Yeah.
And she had been born by vacuum. And I had just like Googled, I didn't know what to do. And somebody was like, chiropractor, craniosacral, those were the 2 things. And she made appointments, signed AMA, because they were like, we can't let you leave until breastfeeding's established. And we're like, this is not happening.
Right.
So she went straight to the craniosacral first. And I remember I went with them and I was like, I don't even know what he did, because it just looked like he was barely touching the baby.
Yeah.
And he stopped crying and she nursed, and they followed it up with the chiropractor just to like seal the deal,
Yeah.
kind of thing. But I was like, what magic is this? And then with Benjamin, he had his tongue, like muscle memory was kind of stuck to the roof of his mouth. And so he couldn't like get his tongue under a nipple or a bottle. And then you came to the hospital and adjusted him. And 10 minutes later, he latched onto both, no problem. And his tongue never like went up again. It like rested, you know?
Yeah.
Yeah, and just so everyone knows, like craniosacral and chiropractic for babies is very gentle. It's especially chiropractic. It's not this like cracking neck thing that a lot of people think it potentially might be. It's very, very gentle.
Yeah, it's all super gentle. It looks like I say it like, and I know other chiropractors hate it when I say it, but it's really true. It looks more like a baby massage. It looks like we're not really doing anything. We just kind of sit there and like, you know, especially with the dynamic body balancing, sometimes the baby will kind of unwind. So they'll move, but they're doing it. And I'm just kind of holding that space. But we do, for an adjustment, it's about 2 to 6 ounces of pressure. So if you were to take your finger, put it on like your eyeball before that even starts to feel uncomfortable, that's the amount of pressure. I often say it's like if you were to go to check the ripeness of a tomato, you're going to delicately push it, right? You're going to delicately squeeze that tomato. You're not going to pick it up and make ketchup right there and at the store. So it's very, very gentle. And I think often people are surprised at how gentle it is. As far as having a chiropractor who knows how to work with babies, we're trained to be very gentle. So it looks, there's no bending, twisting, popping, cracking, anything like that. Very, very
well,
subtle.
great. How can people who are local get in touch with you? And we'll include everything in the show notes.
So if they have any direct questions, they can email me, Dr. Jen, DRJEN at acornchiropracticclub.com. They can reach out to our office, Acorn Chiropractic Club, and make an appointment, come on in, whatever. But yeah, find me on Facebook, whatever. You can always get a hold of me.
Thank you. And apparently we're going to have you come back to talk about ultrasound.
Yay, thank you.
Thanks, Jen. Bonus clip. Here we go.
So the question was like, do you go straight to a TI revision, or what can we do first? And in my opinion, it makes sense to have body work done first, because when a baby comes through the birth canal, they're supposed to help integrate their primitive reflexes. So with the birth process, they go through and they rotate through the birth canal. And when they rotate through the birth canal, they're stimulating different primitive reflexes. But what that can sometimes do is cause a torsional injury in the baby. There's a lot of pressure put on the baby's head through the birth canal. And so when that happens, often at birth, we'll see like jaw stuff or tightness in the upper neck and that kind of stuff. And what that does is it kind of torques that tissue. So it kind of will cause like, if you have like a hand towel and you twist it, it'll cause like that tissue to be bunched. So sometimes what some people will say is a tongue tie, I see is just kind of like torqued tissue. So if the jaw is misaligned, it can cause like kind of rotation in there. I also do a lot of work on the tongue itself because it's a big muscle that's anchored all the way down. And I also do hyoid work, which the hyoid, I believe, is the only bone in the body that's not connected to other bones. So it's a free floating bone at the top of the neck. But going through the birth canal, it makes sense that if there's that rotational component, and let's say they get vacuumed, or it's a home birth and you have to use a little bit of traction to help them out, or whatever, it can kind of cause that rotation in there. So a lot of times,
or cesarean, there's a lot of cranking on the head in cesareans.
Yes. Yeah. So perhaps they don't go through that torsional component through the vaginal canal, but there's with the cesarean, they're trying to get something to pull baby out. And that can put rotation in their jaw, which can appear like a tie, but then we start releasing the hyoid and their jaw and their tongue. And what that does is it releases that and allows for it to kind of release that torsion or that tension, so it doesn't appear as a tie. So I don't even like to talk about ties the first visit unless it is really, unless it's one of those situations where it's like so incredibly obvious, it has like a neon sign, and like the tongue is very, very anteriorly tied, or or the lip is just, there's no, I still like to do work first because I do feel like it's going to be a cleaner cut. Because if you take it, just imagine you have a hand towel and you twist it really, really tight. If you were to cut through that and then unwind it, it's going to be all frayed, right? So what I like to do is get everything untorqued or untwisted. And so then if there is a revision that is necessary, when it is released, it is a clean release and there's not like a bunch of frayed
tissue. That's a good analogy.
Yeah. So, and a lot of times, I'll have parents, one of the things with this is like, with these babies, sometimes they're not able to breastfeed at all. So they're losing weight, they're doing, whatever. So the expediency is more important. But for the most part, I really like to work on the baby beforehand. And what I often find is exactly what you were saying, where we don't even need to do a revision, but it appeared like a tongue tie, but really what it was is torsion in those muscles, in that fascia and in that jaw or head or cranium. And all of that is playing a role on torquing it and creating more tension that we can release through very gentle body work. And we don't need to do a revision, which is ideal in my opinion.
Cool, thanks, Jen.
Thanks everybody for listening. You can find us at Born Wild Podcast on Instagram. For inquiries or feedback, you can email us at bornwildpodcast@gmail.com. You can find me, Emma Ray, on Instagram at Emma Ray, REA.
Sophia at sophiabirth.com.
And me, Leah, at Bay Area Home Birth.
We would really appreciate it if you would rate and review us on Apple Podcasts. It helps us reach more people. And as always,
Stay wild.